Hey everyone, this is Spencer, Oncology Pharmacy Resident, and for this clinical pearl, I'll be talking about a new medication in the oncology world for the treatment of refractory metastatic triple-negative breast cancer, which is Trodelvy or Sacituzumab govitecan. First, I'd like to just go into a basic overview of breast cancer. So we have the American Cancer Society estimates for breast cancer for 2020 that there's going to be around 280,000 new cases of breast cancer, resulting in 42,000 deaths. A triple-negative breast cancer, meaning that there are no known drivers of the cancer, so it is estrogen or progesterone receptor negative as well as HER2 receptor negative. A triple-negative breast cancer accounts for around 10 to 15% of all breast cancers, and it's most common in younger African American women who do have a genetic BRCA1 mutation. We do know that triple negative breast cancers are more aggressive than other types of breast cancer in that they grow more quickly, are less likely to respond to chemotherapy, more likely to recur after treatment, and are more likely to have metastasized at the time of diagnosis. Here we have a graph that shows the 5-year relative survival rate for all types of breast cancers, and then on the far right we can see the 5-year relative rate of survival of triple-negative breast cancer. So dependent if it's localized, meaning if it's just confined to the breast without any extension beyond the breast, regional, meaning that there is extension to adjacent organs, or spread to regional lymph nodes, and then distant, meaning metastatic. We can see in all stages that triple-negative breast cancer is going to have a worse prognosis, especially once it has metastasized. So 11% 5-year relative survival for triple-negative metastatic breast cancer compared to 27% 5-year relative survival for all breast cancers that are metastatic. Looking at treatment for triple-negative breast cancer, unfortunately triple-negative breast cancer has fewer treatment options compared to other invasive breast cancer because it does lack any specific targets. If it is non-metastatic, surgery is an option, and then chemotherapy is going to be the backbone of therapy and can be used in the neoadjuvant setting, so being used prior to surgery to try to shrink down the size of the tumor so that it is more easily resectable, or in the adjuvant setting, so after surgery, reducing the chances of the cancer coming back. Radiation might also be an option depending on certain features of the tumor. Here we have the initial treatment for metastatic triple-negative breast cancer, which just again consists of either combination chemotherapy or monotherapy options. It should be noted that standard chemotherapy is associated with low response rates. The treatment options for refractory or relapsed metastatic triple-negative breast cancer, again, is going to be some sort of chemotherapy. It should be noted that standard chemotherapy is associated with low response rates of around 10 to 15%, as well as a short progression-free survival period of around 2 to 3 months among patients with pretreated metastatic triple-negative breast cancer. And at the bottom, you can see the addition of Sacituzumab as an agent for relapsed or refractory metastatic triple-negative breast cancer. Getting into the newest agent in the treatment for relapsed metastatic triple-negative breast cancer, the monoclonal antibody Sacituzumab govitecan. I wanted to take some time first to discuss the background of monoclonal antibodies. The unique thing about monoclonal antibodies is the suffixes that they have within their name actually do tell you a good deal of information about how they work. We can see the third to last suffix are going to tell you where the effect of the monoclonal antibody is going to be. So for this TU, it's going to be tumor-directed, LI, immune-directed, CI, the cardiovasculature, and then VI, virus-directed. Referencing pembrolizumab, we know that it has the LI in its name, meaning it's going to be immune-directed, as we can see, since it does work with T cells. The second to last suffix is going to tell you where the monoclonal antibody originates from. MO meaning it's derived from mouse DNA, Z meaning chimeric, a little bit of human and mouse, ZU meaning humanized, and mu meaning fully human monoclonal antibodies. And then of course the last suffix is going to be the MAB, stating it's a monoclonal antibody. For Sacituzumab, we see that it has this TU, meaning it's going to be tumor-directed, having direct action on the tumor, ZU, meaning it's humanized, and then of course it's a monoclonal antibody. I had referenced where the monoclonal antibodies originate from. Here we have a diagram of the monoclonal antibody origins. So if it comes from a mouse, it's going to be 0% human and 100% mouse DNA. Chimeric, meaning around 65% human, the rest this mouse DNA. Humanized, greater than or equal to 90% human with slightly less mouse DNA, and then 100% human for fully human monoclonal antibodies. So, how is sacituzumab govitecan classified? We do know that it is a monoclonal antibody, but it is also an antibody drug conjugate. What that means is that it has cytotoxic agents which are linked on to a monoclonal antibody, and we'll get into the mechanism of action in a little bit. But the antibody is going to target this anti-TROP2 antigen, and then it's going to release its cytotoxic agent SN38, which is a topoisomerase 1 inhibitor. As a good review, just wanted to take some time to discuss what other antibody drug conjugates that are out there. So the question of which of these are also antibody drug conjugates, the correct answer is going to be, of course, all of them, with the newest of them being the enfortumab vedotin, as well as trastuzumab deruxtecan. Now jumping into the mechanism of action for sacituzumab govitecan. So as we stated, it is an antibody drug conjugate that consists of a humanized anti-trophoblast cell surface antigen 2 monoclonal antibody, which is coupled to the topoisomerase 1 inhibitor SN38 via that cleavable linker. We know that TROP2 is overexpressed in many epithelial cancers and is associated with cancer cell growth, and has also been found on breast cancer tumors. Once there is the interaction with that TROP2 monoclonal antibody and receptor, the sacituzumab govitecan is then internalized, and then once internalized, the SN38, the cytotoxic portion of the medication, is released within the tumor, which it can invoke intracellular damage as well as damage to the tumor microenvironment, which ultimately leads to DNA damage, apoptosis, or cell death. For the visual learners out there, here is just the diagram of how the medication works. So we have, again, just to orient you, we have the antibody with the TROP2 receptor, the linker, which links the cytotoxic SN38 topoisomerase 1 inhibitor. So here's the tumor cell. There is going to be an interaction between the antibody and the TROP2 antigen on the cell surface. Sacituzumab then gets internalized, where that linker is dissolved and the cytotoxic agent is released, leading to DNA damage. Getting into how topoisomerase 1 inhibitors work. Topoisomerase 1 is an essential enzyme that relaxes DNA supercoiling during the replication and transcription process. By inhibiting topoisomerase 1, the DNA is going to remain supercoiled, and when it comes time for transcription and replication, there's going to be too much strain within the DNA, and it's going to cause the single strand DNA breaks. Sacituzumab govitecan is not the only medication that relies on SN38 for cytotoxicity. The other agent currently on the market is actually irinotecan. Irinotecan relies on its active metabolites, one of them being SN38 for toxicity, but with irinotecan, it's going to work a little bit differently since that one is not bound to a monoclonal antibody. But this does give us some insights into potential for toxicity. Now we'll take a look at the efficacy of sacituzumab, why it was approved, and why we will start to be using it. There was one study of sacituzumab in refractory metastatic triple-negative breast cancer that included 108 patients. The response rate in the trial was 33.3%. with 3 of those patients having a complete response, meaning the disappearance of all target lesions, as well as reduction in any lymph nodes that were affected to a size of less than 10 millimeters, and those with a partial response, meaning at least a 30% reduction in the diameter of the target lesions. The median duration of response was 7.7 months, which is a big advancement as compared to the 2 to 3 months progression-free survival that I had mentioned earlier. Clinical benefit rate was 45.4%. That means that patients either responded or had stable disease for at least 6 months. The median progression-free survival was 5.5 months. Overall survival was 13 months. and median duration of treatment was 5.1 months. This is significant in that the median duration of treatment with standard chemotherapy is around 2.5 months, so we see a double in the treatment time. It should be noted that in this trial, patients received an average of 3 lines of therapy before sacituzumab, showing that it does work in extensively previously treated patients, and the range of therapy before sacituzumab was 2 to 10 lines of therapy. Taking a look at dosing, this is a weight-based medication. They do recommend that a patient's weight is updated at the beginning of each treatment cycle and at any time when a patient's body weight fluctuates by greater than 10% from the previous dose. The dosing is 10 milligrams per kilograms on days 1 and 8 of a 21-day treatment cycle, which is continued until disease progression or unacceptable toxicity. Being a monoclonal antibody, they do recommend pre-medicating for hypersensitivity reactions with acetaminophen, diphenhydramine, and famotidine. This medication is moderately emetogenic, and they do recommend using institutional antiemetic regimen. So for Monument Health, that would be palinositron as well as dexamethasone prior to therapy. For dose adjustments of this medication, there are no dose adjustments recommended per manufacturer's labeling for renal impairment or hepatic impairment. They do make mention that exposure to SN38 may be increased in patients who have decreased UGT1A1 activity. Brief overview of the administration. So of course, making sure we give the pre-medications at least 30 to 60 minutes prior to the sacituzumab dose. The initial infusion of sacituzumab is recommended to be given over 3 hours, with subsequent infusions over 1 to 2 hours. Observe the patients for at least 30 minutes after the infusion completes. If the patient does develop an infusion reaction, they recommend to slow or interrupt the infusion. This medication should be protected from light, and it is a hazardous drug, so the necessary precautions need to be taken. For supportive medications, for nausea and vomiting, since it does have moderate emetic potential, we use palinositron and dexamethasone prior to the infusion, and then after the infusion completes, the patient will then use prochlorperazine twice daily for 3 days, starting the evening of chemotherapy, and they're able to use that as needed with a maximum of 40 milligrams a day. This medication can cause diarrhea, just like irinotecan, so for that, they do recommend using loperamide at the standard dosing up to 16 milligrams per day as the maximum. If the patient does develop acute diarrhea during the infusion, you can use atropine since it is going to be more of a cholinergic side effect. And depending on the extent of the diarrhea, you can actually use atropine prophylactically. Monitoring for this medication, so it's going to be a CBC, a CMP on days 1 and 8 of each cycle of therapy, and withholding therapy on days 1 of the cycle if the ANC is less than 1500, and withholding therapy on day 8 if the ANC is less than 1000. In the study, sacituzumab caused nausea in 67% of the patients, neutropenia in 64% of the patients, with 26 of those patients having grade 3 neutropenia and 16% having a grade 4 neutropenia. Diarrhea occurred in 62% of the patients and anemia 50% of the patients. And then less so adverse reactions of anemia, infection, leukopenia, vomiting. Should be noted that this medication can cause alopecia, so patients should be aware of potential hair loss. And then again, the possibility of hypersensitivity reaction. There are specific adjustments depending on what toxicity is experienced. For example, if a patient develops grade 3 neutropenic fever, the first time you would reduce the dose by 25% and then administer growth factor support with every subsequent cycle. The second time, reducing the sacituzumab dose by 50% and continuing that growth factor support, and if it happens again, discontinuing the sacituzumab. For non-hematologic toxicities, so depending on the grade, again, we're going to see reduction of the dose by 25% with the first occurrence, reduction by 50% with the second, and discontinuing with the third. That is all that I have for you today. As always, if there's any questions, feel free to reach out to me at slehman1@monument.health. Thank you and have a great day.